So we left off on Friday talking about how we regulate heart rate. Okay. And that the primary way that we do this is by having input. And by input, I mean either hormonal or neurotransmitter, depending upon how you want to classify it, input to the SA node. Okay. In the absence of anything else happening, the SA node will fire intrinsically somewhere between 70 and 75 times in a minute. Okay. So we call this input that we're going to get from neurotransmitters, call this extrinsic control. Okay. Extrinsic control. So there's autonomic nervous system input. It originates in the cardiovascular centers in the brain. Okay. And we get sympathetic input from epinephrine and norepinephrine that increase heart rate, or parasympathetic input from acetylcholine that decreases heart rate. Right. This is the age-old thing. Right. If I ask all of you to stand up and do Dead Poets Society for us, stand up on your desk and sing a song to us or just something, we're going to get a sympathetic response, a stress response that will raise your heart rate. We turn the lights down even more. We put on some nice soft like rainfall music. We do some deep breathing. That stimulates the vagus nerve. It stimulates the release of acetylcholine and it lowers your heart rate. Okay. It lowers your heart rate. So we have these large numbers of sympathetic and parasympathetic neurons that innervate the atria as well as they innervate the SA node. And the ventricles are going to primarily only receive input from the sympathetic system, which we'll talk about how that regulates stroke volume in a few minutes. Okay. So when we begin exercise, when you do low to moderate intensity exercise, one of the ways that we can increase your heart rate is not to release epinephrine and norepinephrine. It's to stop releasing acetylcholine. If we at rest in most people have some level of parasympathetic input that lowers your heart rate below that 72 or so beats per minute, if we take away the acetylcholine, that raises your heart rate up towards that intrinsic firing rate. Okay. So early on in exercise, one of the things that we tend to do is we remove parasympathetic. Then if we need a further increase, we can dose sympathetic on top of it. Okay. So that's the interplay that we're going to get on most of those things. Please don't ask me like at what heart rates is the parasympathetic all gone and at what heart rates do the epi and norepi begin to take over, because it's going to vary from person to person. It's going to vary from situation to situation. This is a graphical depiction. Okay. Here are the cardiovascular centers, right, in the brain. You can see this sort of sympathetic output, autonomic nervous system output that's coming out. You've got parasympathetic nerves, vagus nerve here in purple. You've got the sympathetic nerves here in green. And you will note that we get, right, both sympathetic and parasympathetic on SA node, AV node, parasympathetic in the rest of the atria, and then sympathetic input almost exclusively into the ventricles, which we'll talk about in a second. Okay. I really like this depiction, okay, of going from rest to walking to jogging fast to kind of all out exercise. So here's percentage of max VO2. Here's your heart rate on the y-axis, and then showing how we're going to go from rest up to our age predicted max heart rate that we're minusing or removing vagus, removing parasympathetic, then adding sympathetic on top of it. Okay. I really like that actual depiction. It's not quite this clean. Okay. You're going to remove some, you're going to add some, right? It's not quite this, like everything else, it's not quite this sort of cut and dry. But I like that kind of, that it shows in general what's happening. Okay. So I can make your heart rate go up by having you remove your vagus input. and then I can make it go up even more by adding sympathetic on top. Okay. All right. That's what we call autonomic or extrinsic control of heart rate. There's an additional way that we can manage heart rate. Okay. There's an additional way that we can manage heart rate. Everybody, look at, if you've got your watch on, look at your heart rate on your watch, please. Okay. Look at your heart rate. Look at your heart rate. We got a heart rate. Now, think about going for a run. Just think about going for a run. Tell me if your heart rate goes up. Like, think about the actual act of running. Anybody's heart rate go up? Okay, Jose's went up, Daniel's went up. Okay. This is called an anticipatory increase in heart rate. All right. We are beginning or thinking about getting peripheral input from blood vessels, joints, and muscles that are also going to play this regulatory thing. So you just think, I can take you and have you stand on a treadmill and your heart rate goes up. I can sit you on an exercise bike and your heart rate goes up before you've done anything. It's this prep response. Okay. Part of that is driven by epinephrine and norepinephrine and removal of acetylcholine, but we've got other things too. We're going to have this input from blood vessels, from joints, and from muscles. We have what are called chemoreceptors that sense chemicals, and mechanoreceptors that are going to sense movement or force production or something like that. And input from these things modifies parasympathetic or sympathetic outflow to bring about an appropriate cardiovascular and especially a respiratory response. So the act of moving increases the moving in and of itself, changes heart rate. Okay. Moving an arm or a leg into a position to exercise changes heart rate. Okay. When you are actually exercising, okay, when you get metabolic byproducts made in muscles, that will stimulate chemoreceptors, and that can increase heart rate and cardiac output, and also try to send more blood to those particular areas. So there's all of this linked in control that's going to function primarily to match cardiac output and the amount of oxygenated blood that we need in a muscle to what that muscle demands, right? So we're going to increase central circulation. We're going to send more blood, which we'll talk about probably on Wednesday, to our working skeletal muscle. And then we want to match that metabolic rate. Okay. Look, we already talked about stroke volume, so I've already showed you guys that particular slide. Okay. So in how we control cardiac output, we've done heart rate. Now, stroke volume is more complicated. Okay. But in some ways, it's more important. Okay. It's more important. We said on Friday that if we assume that all of you guys, almost all of you all, are going to have an age predicted max heart rate within a beat or two of each other, and that whoever has the largest cardiac output during exercise is going to have the highest VO2 max and probably be the best endurance athlete. If your max heart rate is all roughly the same, then to have the highest cardiac output, you have to have the largest stroke volume. Okay. And then a lot of that is determined by heart size. So there are some other things that go into that, though, in regulating stroke volume, right? And so we're going to walk our way through the idea of what's called preload, afterload, contractility, the heart rate, and the role that they play in regulating stroke volume during exercise. Okay. So we're going to start off by something called preload. Preload is, another word for preload is end diastolic volume. Preload is the amount of blood that goes into the left ventricle during left ventricular diastole. Okay. Preload. How much blood goes in? How much water goes into the water balloon, right, before you turn when you turn the faucet off before you throw it at somebody? Okay, how's that?
So during left what?
During left ventricular diastole. during filling of the left ventricle. Okay. Some books will refer to it as in diastolic pressure in the left ventricle. The volume, the amount of blood in there controls the amount of pressure, right? You run more blood in, the pressure inside goes up. Okay. You guys learned about this in human phys, I know, but we'll talk about how and why it matters in a little bit of detail here now. Okay. The reason that preload matters, the reason that the amount of blood going into the left ventricle matters is that the heart and cardiac muscle functions very much like skeletal muscle does. Okay? Like skeletal muscle. Everybody stand up. Everybody stand up. Okay? We're going to try two things. Two things here. If I told you you need to punch your neighbor, do not punch your neighbor. Very clear. Okay? What's the first thing you would do if I said you got to punch your neighbor? Fist? What are you going to do? Winding up, right? I like landing. It's like Popeye. Okay? Okay. You're going to wind up. What are you doing when you wind up? I'm preloading. Okay? What else is happening? We talked about this when we did skeletal muscle. As I pull back, what's happening? Somebody sort of started to say it over here. No? Okay, fine. We'll do a different example. Try to jump and touch the ceiling. Very clever, Abby. Very clever. Okay. Seriously, try to jump and touch the ceiling. Okay. What's the first thing you did? Oh, my guy's in the back, the ceiling's closed. Okay. Y'all are tall, well played. What's the first thing that you do?
Go down.
You go down. Why do we go down? When I go down, what happens?
Store energy.
I'm storing energy. How?
Putting tension on our muscles so they can.
I'm putting tension. We're really close.
Elasticity.
Elasticity. What do I have to do to get the elasticity to work? Stretch. Thank you. It's called a stretch shortening cycle. I sink, I stretch, I store elastic energy. So then when I jump, I get force from the elastic energy plus force from my muscles. Thank you. Sit. In the heart, when you fill up the left ventricle, if you fill it enough, you stretch the cardiac muscle. You stretch out the left ventricle. Okay? It's just like stretching out a balloon when you fill it with air or with water. Okay? So as it stretches, when it then turns around to contract, it's going to contract more forcefully. And if it contracts more forcefully, it will eject more blood out into the aorta. Okay, Fran, do you have a question?
We'll stretch and then we hold energy and something.
So when we stretch either skeletal muscle or cardiac muscle, we store elastic energy in the connective tissue. So that when you then turn around and contract, you get force from the actin and myosin in the cardiac muscle or skeletal muscle, plus force from the elastic energy. Okay. And so this is what's called a pressure volume curve, okay, or a contraction volume curve. And it's related to something called the Frank-Starling mechanism or the Frank-Starling law of the heart. And that's the relationship. Frank-Starling describes the relationship between stretch in the cardiac muscle and stroke volume, or specifically stretch in the left ventricle and stroke volume. Okay. It's just like sinking down before we do a vertical jump. As ventricular end-diastolic volume, as we put more and more blood into the left ventricle, preload increases then contraction force, ventricular performance is contraction force, it goes up. So if the heart squeezes harder, it ejects more blood, stroke volume goes up. Okay. This is the idea of preload. Okay. Of all one of the things that we're going to do, if I can make your preload go up, I can make your stroke volume go up. Okay. And that's going to have some positive outcomes for us. Okay. Anybody ever been lightheaded? Okay. We had someone in the lab, well, I shouldn't say this, but someone in the lab who got a little lightheaded doing an experiment last week. Okay. You know what we did with them? They didn't want to, but I made them. We had them lay down and prop their feet up. Right. We call this rescue position if you've ever had first aid or CPR or anything. Okay. You lay somebody down, you prop their feet up, and it makes it where gravity is going to work with you, pull blood, venous blood from the legs back to the heart. That increases preload, which makes stroke volume go up. And that can be a positive thing. Okay. So we do this in our everyday lives all the time. Tyler, your question was,
So it's pretty much like a trampoline.
it's exactly like a trampoline. Yes. Yes. It's a trampoline, it's a rubber band, however you wanna think about it. Okay. Okay. If we increase preload, stroke volume goes up. Okay. Now, here are just a kind of a flavor of the things that affect preload during exercise. Okay. One of the biggest ones is in number 1, and that is, and I mean this as either cardiac output or venous return. It is not meant to be an equation. It's not meant to be cardiac output divided by venous return. If your cardiac output goes up, a phenomenon that we call venous return goes up. Venous return is blood coming into the heart from the superior vena cava. Okay? From the superior vena cava. When I prop your feet up when you lay down, I increase venous return. Okay? More blood is making it back to the heart. So greater venous return, I get greater preload. Additionally, if your blood volume increases, I get greater venous return, which then gets me greater stroke volume. Okay. One of the problems that we have when you get dehydrated is your blood volume falls because your plasma goes away. So venous return falls, and that can have some pretty serious consequences. Anybody ever done some kind of an exercise and you stop immediately and you don't move and you sit down and then you feel lightheaded? Okay. They encourage most people when you've done very intense exercise, don't stop immediately, like walk a little bit, or if you're on an exercise bike, they want you to keep pedaling a little bit. Part of what happens is this idea of something called the muscle and the thoracic pump. Veins, most of the blood in your body is in your veins. A majority of the blood is in your veins. Your veins are really squishy. Okay. And one of the things that we do if we want to get more blood back to our heart is we can contract the muscles that are around the veins, and it squeezes the veins and forces the blood back towards the heart. Because blood only runs in one direction in your veins. Okay. So when we exercise, especially if we use our legs, we tend to get a lot of blood going to our legs. There's a lot of blood in the veins in the legs. And so by continuing muscle contractions, it's going to force more blood back. Okay. Additionally, the thoracic pump is going to be due to intrathoracic pressure. As you breathe out, or let me rephrase that. As you breathe in, right, you expand in the chest, right? The diaphragm drops, your sternum goes out, and then the area inside your chest goes, it's bigger, that drops the pressure, and that will also make it easier for blood to come back. Posture matters. Gravity is working either for or against venous return. When you're standing like I am, I have to work against gravity to get blood back to the heart. If you lay down and prop your feet up, you can use gravity to your advantage. Heart size matters. one of the biggest ways to change your stroke volume is to have a bigger left ventricle. So get cardiac hypertrophy, bigger left ventricle, boom, bigger stroke volume. And then slightly sort of more complicated is this idea of something called venous tone. Okay. We have a little bit of an ability, not nearly as much as we do in our arteries, but to kind of change what we call tone or the pressure inside of our veins. And if you can make that pressure go up a little bit, you can get more venous return. Okay. So when we get into adaptations to aerobic training, you will see that when I have you train, your heart gets bigger, the left ventricle gets bigger, your blood volume goes up, right? Your blood pressure tends to go down a little bit, and you have more muscle, so you get a better muscle pump. So all of these things are going to work together, and it helps us make your stroke volume go up. Okay. So I talked about how the thoracic pump and the muscle pump works. So we're going to move now to the next kind of thing that contributes to stroke volume. So how much blood gets back into the heart is really, really important. Okay. That plays a big role. The other thing that affects stroke volume, though, is something we call afterload. So preload is blood that goes in. Afterload is essentially in systolic volume. So it's the blood that's left in the left ventricle after a contraction. Okay. So if your afterload is higher, that means less blood left the heart. Right. Probably the primary thing that affects afterload is aortic blood pressure. Okay, is aortic blood pressure. You are having to squeeze the left ventricle and raise the pressure in the heart, right, so that it overcomes and is higher than aortic pressure. Once the blood pressure or the pressure in the left ventricle exceeds aortic pressure, then blood moves from higher pressure to lower pressure, and it will begin to leave the heart. Okay? So your question should be then, well, Dr. Black, what controls aortic blood pressure? I'm glad you asked. We're going to talk about it. Okay? We're going to talk about it. Okay. So things that affect aortic blood pressure are going to be chronic hypertension, something like the Valsalva maneuver, and hypertension or resting blood pressure is also very much controlled by stress, by sympathetic nervous system input, and the sort of resting level of contraction of the smooth muscle that surrounds the aorta and some other blood vessels. Okay. And we call that peripheral resistance, which is actually not on here. I just saw resistance and I thought, oh, it's going to be on there. Okay. People like my father-in-law, who is here this weekend for Halloween, he has hypertension. He has high blood pressure. Okay. So his left ventricle has to contract more forcefully than mine does in order to get blood to leave. You know, if his resting systolic blood pressure is 150 millimeters of mercury and mine is about 110, he's got to get to 151 in the left ventricle to get the blood to go out. I only have to get to, say, 111, right? So for any strength of contraction, I'm going to get more blood to leave. His afterload will be higher. That's going to be an issue. That's why hypertension matters so much. You guys heard of the Valsalva maneuver? You guys know what the Valsalva maneuver is? Everybody Valsalva right now. Right? Hold your breath, contract your diaphragm, okay? Contract your diaphragm, contract your pelvic floor muscles. All of these things contract your external intercostals. What we are doing when you do Valsalva is you're protecting your internal organs from getting squished, okay? When you're going to lift something very, very heavy, I'm going to do a squat, let's just say, right? I Valsalva, and therefore it raises the pressure inside my chest cavity, and it holds and protects those soft internal organs so that while you have that high external load, you don't smush your spleen or your liver or something like all of that, okay? During Valsalva, you may have blood pressures that reach 400 over 250 or something wild and crazy. Okay. Very, very briefly. one of the reasons I had to look at my father-in-law's cardiac rehab program over the weekend. But they talk about when you're doing exercises, don't hold your breath, right? He's already hypertensive and things, and so let's not raise it even farther than all of that. Okay. Okay. That's afterload. The next thing that controls stroke volume is in some ways related to preload. Okay. It's partially related to preload, but then it's also going to have some other things related to it. Is a concept called contractility. Contractility very simply means how much force can the left ventricle generate when it contracts. Okay. So I can make contractility go up by making preload go up. Preload goes up by Frank Starling, I get stretch, I get a more forceful contraction. However, I can also make contractility go up by sending norepinephrine to the ventricles. And it alters the function of the actin and myosin and makes it contract more forcefully. Okay. I did not take my beta blocker this morning. I don't know why. Well, that occurred to me now. I didn't take my beta blocker this morning. But you take a beta blocker and that norepinephrine doesn't work. And so I can't get my left ventricle to contract as forcefully. Okay. But this is one of the main things that's going to go on there. Okay. We oftentimes refer to contractility as the quality of ventricular performance. It's just the strength. How forceful is the left ventricular contraction? Okay. The harder it contracts, the harder it squeezes, the higher the pressure in the left ventricle, the more blood that will leave. Okay. It's very much stimulated by sympathetic, especially norepinephrine on the ventricles. There are other things that we call inotropic agents. This could be some other kind of pharmacological intervention, maybe caffeine, probably definitely cocaine or something like that. Right, meth, something of that nature might make cardiac contraction go up. And then lack of oxygen, so hypoxia decreases contractility, acidosis decreases contractility. So if you're having a heart attack because you don't have any oxygen getting to an area of the thing, you're going to make a lot of lactic acid in the cardiac muscle. That you're going to get these two things, so contraction force goes down. And then if you've got tissue death, there is a condition called oh God, what's it called? The thing where the heart tissue dies and you have a very weak contraction.
Myocardial.
No, it's like a chronic. Why is my brain not working this morning?
Chronic heart failure?
It's not chronic heart failure. Ah,
Coronary artery? No.
pardon? It's not ischemia.
Is it ischemia?
No.
Okay, we're gonna come back to it.
Like
We're gonna come back.
necrosis? I'm like, that's tissue, Deb.
Pardon?
Like necrosis, it's tissue.
Oh,
I don't.
It's okay. Anyway, there are some people that have had multiple heart attacks and part of their cardiac muscle dies. And because of that, it becomes very, very weak. And at some point, it becomes so weak that it cannot contract forcefully enough to actually circulate blood. And it is called something. And basically, once you have it, you're going to die.
All that's popping up is infarction and ischemia.
Congestive heart failure. Thank you. Thank you. Okay. That's better. We're here. We're making it. All right. The last thing that affects stroke volume is heart rate. And this is primarily going to be an issue at very, 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 very high heart rates. Okay. When heart rate gets to be really high, the time the left ventricle spins in diastole becomes incredibly short. Okay. Incredibly short. So the amount of time that you have to fill the left ventricle with blood shrinks. And so at some point, heart rate can become so high that preload falls. Okay. Preload falls. Now, when I say that it needs to be high, I'm talking to you guys, like if your age predicted max heart rate is 200, I'm talking at like 190 or 195 or something of that nature. Okay. And it seems to be more of an issue in people that are less aerobically trained as well. Okay. So when heart rate gets really, really high due to potentially lots and lots of sympathetic input, lots and lots of input from blood vessels and contracting skeletal muscle, stroke volume can fall. Here's some data trying to illustrate for you what I mean. Okay. On the x-axis of this graph, we have rest, exercise at 50% of max VO2, exercise at max. Okay. The y-axis shows stroke volume. How are they measuring stroke volume, you may ask? They're running a catheter, right, into your aorta and measuring blood flow out. Okay. Not really things that we do here in the US very often. Lots of the stuff happens in Scandinavia where their IRBs are a little more open to that. Okay. But we have in the dark circles are individuals that were very highly trained. In the open circles are sedentary individuals. And so what you will see is stroke volume goes up from rest to about 50% of max. And then when you get near max heart rate, stroke volume actually falls because preload falls a little bit in our untrained folks. And for trained folks, it looks like it's falling, but it's really statistically not different. So it kind of comes up and it levels off. As we will see when we talk about the response to exercise, stroke volume goes up in everyone as exercise begins. And then in most of you guys, it's going to level off and plateau off because we plateau off venous return and contractility around 50 to 60% of max VO2. So it goes up and it stays kind of flat. But if heart rate is super high near max, it may dip. And this may be one of the reasons why you get a max test, right? You're maxing out cardiac output because heart rate's basically at its max. Stroke volume is beginning to fall. So cardiac output has essentially maxed itself out. Okay. So in our last 10 minutes or so, we'll talk about the vascular system. We've spent the up until now talking about the heart. We'll talk about the vascular system. We'll talk about arteries, arterioles, capillaries, venules, and veins. Okay, those are our 5 primary blood vessels. Okay, we're going to spend a lot of our time talking about what happens in arterioles and what happens in capillaries, because that's where most of the action and our ability to change things is going to happen. Okay, so arteries are blood vessels that carry blood away from the heart. Away from the heart. Okay. Veins are blood vessels that bring blood back towards the heart. Please note that that has nothing and says nothing about the state of oxygen in the blood that is in those two types of blood vessels. Okay. Most of the time, arteries contain blood that has a high level of oxygen, but not always. Okay. Arteries carry away, veins bring back. Okay. The best illustration of this is you have pulmonary arteries that take blood that has low oxygen from the right atria to the lungs. And then you have pulmonary veins that have high O2 in it that bring blood back to the heart from the lungs. But under most circumstances, arteries have high O2 and they're carrying blood away. Arterioles are smaller branches of arteries. Arterioles and arteries are characterized by a couple of specific structures that let them change their function and help us control where blood goes. Okay? And the big thing that arteries and arterioles have that separates them to some extent from, especially from capillaries and to some extent from veins, is something called vascular smooth muscle. Okay. If you think of a blood vessel as a piece of PVC pipe, okay, it's like a plumbing pipe, then around that pipe, okay, in arteries and arterioles, circling around that pipe is something called vascular smooth muscle. And that muscle has an ability to contract and relax, to contract and relax. And as it contracts, it squeezes the pipe closed, or at least it squeezes its diameter down. And as it relaxes, it lets the pipe expand out. Okay. So using PVC pipe was probably a bad analogy. You should probably think about a blood vessel as like a fire hose or something that has an ability to be sort of squish or to let it get bigger in the midst of all of that. Okay. Blood goes from arteries into arterioles, then into the capillaries. Arteries and especially arterioles are collectively referred to as something we call resistance vessels. Resistance vessels. And what that means is because they can change their diameter, we can make it easier or more difficult for blood to flow through those vessels. And so from a fluid dynamic standpoint, this is a concept called resistance. It's the resistance or the ease or difficulty of the fluid to move through. So when resistance rises, it's harder for a fluid to move through that particular area. When resistance falls, it becomes easier. Okay. And so by changing their diameter, by contracting and relaxing the smooth muscle, we change the diameter of our arterioles and we make it easier or more difficult for blood to move through them. Okay? And that's partially how we control where the blood goes in the body. Okay. Capillaries are our smallest vessels. They're very, very tiny, very narrow. Usually they're only big enough for one red blood cell to pass through at a time. They look like Swiss cheese. They're very whole. They have they're called fenestrations. Okay, they have lots of holes in them, and that allows for the easy passage of ions and glucose and things through. And veins are going to bring blood back. As I said a few minutes ago, they're very squishy. Veins have a special structure that arteries don't. That structure is called a valve. And they have a valve in them, and the valve, when they close, prevents blood from flowing backward. Okay? So it looks like these flaps that look like this. So you're going to get blood pushes through, it opens the valve, and then it closes back, and it can't flow backwards. And that's partially good, because if you didn't have valves, all the blood would be in the veins in your feet all the time. Okay? You'd have all the blood down there, and you'd be in a bad way. Okay? Most of your blood, or a majority, say about 60% of the blood in your body, is in your veins at any one given time. Okay? Here's a cartoon depicting arteries, arterioles, venules, veins. Okay? Veins have some vascular smooth muscle. Arteries and arterioles have way more. Here's our capillaries, where we have just trillions of capillaries in our body. They're going to be the place where we're going to bring blood down actually to the different tissues. Okay. I want to point out one other interesting, sort of structure that's going to exist in arteries and arterioles and in veins, but it's going to have a big issue on our function in arteries and arterioles. And that's going to be this inner layer of cells right here, or right here, okay? And the innermost layer of cells in a blood vessel is called the endothelium. The endothelium. Okay? Endo meaning inside, thelium is just a layer of cells. The endothelium is going to be a really, really important regulator of the diameter of arteries and arterioles. And we'll get into the how and why of that in a little bit. Okay. Do you guys have heard of the phenomenon of something called atherosclerosis? You guys know what atherosclerosis is? In people that have atherosclerosis, you get these fatty deposits and these fatty plaques that cover up the endothelium. And then the endothelium can't respond to changes in blood pressure and blood velocity the way it's supposed to. And so you lose some ability to regulate changes in vessel diameter. And that you lose the ability to regulate blood pressure and to regulate some of where blood's going. And that's one of the ways that atherosclerosis can be so dangerous to us. Okay. Some people not all, but some, will refer to arterioles into capillaries as something called microcirculation. Macrocirculation is aorta, heart, kind of big arteries. So what you can see here, okay, is we've zoomed in and we've put dye in, and you can image the individual arterioles and the capillaries here. So this is a picture of microcirculation. Other people will also refer to what you see here as the vascular tree. Okay, it's the vascular tree, because it looks like the branches on a tree. And so what you see with all of this is these here, these largest ones are what we call a primary arteriole. So you can imagine this is in my bicep, let's just say. The brachial artery brings blood here. It squinches down and it branches off into a primary arteriole. And then at essentially 90-degree angles, we get a secondary arteriole, then a third order arteriole, then a fourth order, so on, so forth, until you get down to the smaller ones that lead into capillaries called tertiary or terminal arterioles. Okay. And then these very, very, very small little stained vessels out here are going to be the capillary. Right? The reason I show you all of this is every tissue in your body has a vascular tree that looks like. And when I want to change how much blood goes to a certain tissue, what I'm going to do is basically take these primary and secondary arterioles and either open them up wider and let more blood go in, or I'm going to squeeze them down and prevent blood from going. And so if I take this and I squeeze these arteries closed, no blood makes it past. We get very little what we would call blood or perfusion into the capillaries. If I take these though and I open them up, right, they get opened wider, more blood will go in, and then more blood's going to make it down into the capillary. And this is how we use arterioles to control where is the blood in your body going to go at any one given time. Okay, where's it going to go? And so what we'll do with all of this is on Wednesday, we'll pick up by starting talking about what are the signals that tell arterioles to close and what are the signals that tell them to open up so that we can use them to control where the blood. Okay, very good. Thank you guys. I'll try to be here sooner on Wednesday, and we'll talk to y'all then.
The hormonal control assignment is due Wednesday night. Please double check your submissions. For some reason, the PDFs, if they're editable, are showing up blank. So just make sure that